First off, I would like to welcome back everyone to the day two of the See All of Me, the intersections of medical myths and distrust, and its impact on transgender health, HIV care, and prevention summit. My name is Neve Anderson, and my pronouns are she and hers. And I am an identity consultant with Denver Health's Prevention and Training Center, as well as the founder of my very own consulting agency, Simply the LLC. And I'm one of your MCs for today. If we were here yesterday, let's get some hearts and some thumbs up in the chat. Well, as we all know, yesterday was such a powerful day. And we discussed intersectional approaches to gender affirming care. We had a profound panel exploring gender identities and accessing care. And we finished the day off examining how to decolonize transgender health. But as we all know, today is going to be just as dynamic. And to kick off today's event, I'm going to pass the mic over to my co-MC, Miss Marissa Miller.
Well, thank you, Neve. And we are so excited for you guys being a part of day two. Did we have a wonderful time learning about medical mistrust in day one? I heard the fantastic, the amazing Dr. Tatiana Moulton gave everyone exactly what they needed yesterday. So we're excited for day two. I am Marissa Miller again. My pronouns are she and they for the purpose of this call. I am the new Executive Director of Trans Solutions Research and Resource Center. We are an agency that is located in the Midwest in the state of Indiana. And so we are so excited to be a part of this. I have the honor and the pleasure and the privilege of introducing Shawn Demmons, MPH, pronouns he and his. Shawn is the director of the Bay Area North and Central Coast Pacific AIDS Education and Training Center. Shawn is a dedicated public health expert with deep knowledge of improving the lives of transgender people. Shawn is going to moderate our next panel, The Ecological Perspective of Deconstructing Medical Trust in Trans Health. The ecological perspective of deconstructing medical mistrust in trans health. Listen, Shawn is a friend of mine. Shawn is a colleague of mine. And if you will raise your hands in the chat section and with me, welcome Shawn to the platform, I'd be most appreciative. Can we do that?
All right. Thank you, Marissa. That was a great introduction. And I want to say hello and welcome to everybody while I find what I'm talking about. There we go. So good morning, everyone. As Marissa said, I'm Shawn Demmons. I work with the PATC in the Bay Area North and Central Coast region. This morning's plenary panel will explore how providers can deconstruct medical mistrust and mitigate its negative impact on access to care for trans people by engaging an ecological lens. As we know, ecological models lead to the explicit consideration of multiple levels of influence and can guide the development of more comprehensive interventions. Exploring this perspective today will build upon the overall theme of the conference, the need for providers to see and understand all of me. In order to interrupt medical mistrust or to provide comprehensive, affirming, and culturally responsive healthcare for trans people, providers must be able to see all of the identities and understand the psychosocial context of the lives of their transgender patients. The objective for this panel are to describe how an ecological perspective can combat the negative impacts of medical mistrust, identify and discuss the tools, actions, and policies needed to correct gender-affirming clinical programs, to create gender-affirming clinical programs, and to discuss advocacy efforts to address institutional barriers to gender-affirming clinical care and treatment programs. You're in for a treat. We have a dynamic, powerful powerhouse of trans women of color panelists for you today. First up, we'll hear from Jenna Rapues. Jenna is my friend and colleague, first and foremost. She is also the director of Gender Health SF. Gender Health SF is an innovative program of San Francisco Department of Public Health that provides access to gender-affirming procedures and related education and preparation services to eligible, uninsured transgender adult residents in San Francisco. Prior to joining SFDPH, Jenna was the interim director of UCSF's Center of Excellence for Transgender Health, where she led a national capacity building and technical assistance program working to increase access to comprehensive, effective, and affirming healthcare services for transgender and gender non-binary communities. Next up, we'll hear from Reverend Valerie Spencer, who needs no introduction, but I'm going to give one. Ms. Reverend Spencer is a nationally recognized transgender activist and public speaker, a behavioral health therapist and holistic life coach, and the principal and founder of Valerie Spencer Consulting, where she leads special projects focused on community development, health disparities, and public policy. Reverend Spencer has worked in the arena of social services with local and federal government entities, health departments, universities, community groups, conferences, and community-based organizations for over 2 decades. Last but certainly not least, we have Ms. Cecilia Gentili. Cecilia is an advocate, organizer, and storyteller working at the intersections of sex work, immigrant rights, incarceration issues, and trans liberation. Originally from Argentina, Cecilia came to the United States and survived for 10 years as an undocumented immigrant, gaining a living through sex work. She has years of experience working in direct services with organizations like the LGBT Center and the Gay Men's Health Crisis. Cecilia is also a founding member of Decrim New York, a coalition working towards the decriminalization, decarceration, and destigmatization of people in the sex trade. And she's the principal and founder of Trans Equity Consulting. Join me in welcoming our panelists to the plenary panel this morning. As I said, the format is each panelist will speak for 20 minutes to how they incorporate the ecological perspective in their work, and that will be followed by a moderated discussion. So with that, welcome to all of our panelists, and I will turn it over to you, Jenna.
Thank you, everyone. It's a pleasure to be here. My name is Jenna Rapues. I use she, her pronouns. Before I kind of jump into kind of the work I do right now with Gender Health SF, I thought it'd be really great to kind of provide some context. And so I think the one thing that I really want to put out there is that I've actually been working in public health, particularly the San Francisco Department of Public Health, for actually 20 years now. And to put that into context, so important to think about where we came from and where we are today, because part of the work that we've been doing, that I've actually been doing today, has been so much of the work that many community advocates, particularly grounded in HIV prevention work, had really imagined, and kind of the future is now, and kind of where we're at today. So with that, I kind of want to put this context around kind of HIV prevention back 20 years ago, 1999, when I first started working at the Department of Public Health, as someone who actually transitioned in 2000, so a year after I started my work at the Department of Public Health. Really pivotal time in how we think about inclusion, representation of trans folks in HIV prevention. Also important to think about at the time was this narrative around lack of data and inclusion of trans people around HIV prevention work and prioritization, which at the time related to how much resources and funding allocations were directed to the community. Also too, really important to think about what at the time was this idea of the ongoing narrative, particularly within the place that I work in, which is Department of Public Health, was again, trans community are so small, we don't have enough data to really speak of the experiences of the community. Therefore, we don't know how to really respond effectively around how we think about prevention services, care services that really speaks to the needs of the community. And so I think in 2002, the Department of Public Health actually put out the first publication that was really instrumental in really reimagining and really laying the foundation for data that speaks to the community needs of the population that's centered around HIV prevention. So I credit all the folks who were, I imagine, as my mentors and folks that I looked up to at the time, such as Cecilia and Tamara Ching and Joanne Heatley and Ms. Major and Ms. Valerie Spencer and Davi Salcedo, who have really done the foundational work in really advocating for inclusion, representation, and the need to really center the experiences of our communities around HIV prevention work. And within that time frame too, I want to kind of put into context. I think so much around the work that many of our advocates have really centered on was the idea of lack of data. And I think later on in 2010, I believe, there was a lot of work around SOGI implementation and policy, and a major focus of my work at the time, as I think around 2010, was really reimagining working with the department, think about how do we break these barriers around exclusion of trans folks around data and lack of representation. So we worked on really implementing a SOGI policy for the department, which was so necessary, right? Because we didn't have necessarily systems in place or tools in place that really captured the population and really spoke to the needs of the community around HIV prevention. And so, so much of that work has really contributed to kind of where we are today, and so much including the research that has evolved during that period to really speak to evidence-based practices that are so important to the community. One thing that really struck me at the time too, in thinking about barriers that exist for trans folks, and historical trauma with providers and the experiences of discrimination and transphobia, was this notion of these barriers existing to fully engage with care providers around accessing gender affirming care. And so, at the time, with the local advocates in San Francisco, I think I would imagine around 2010, this idea of not just HIV prevention services, but what are the needs of the community at the time that was missing around accessing transgender care. One of them is actually really having access to transgender affirming care, and what that looked like too, right? And so for trans folks, that meant having access to hormones, or having good behavioral health services, or having providers that were culturally aware of providing gender trans care for folks who were seeking trans affirming care, whether it be social transition or medical transition. And so I think so much of the work around in that time too centered around best practices for providing good care for trans and non-binary people. And so I bring that kind of context to kind of like where we're at today, and kind of what I'm doing currently right now with Gender Health SF. And I think about this question all the time, which is, yes, we work so much around access and inclusion and representation, but to kind of like where I am today, I hold this reality of what does good trans care really look like? How do we build capacity of our care providers, provide gender affirming care that is patient-centered, that is responsive to the other experiences that many trans and non-binary people experience around social determinants of health and increased health outcomes. And what are the needs and priorities of the community, because that's currently evolving. And I think that's something that I think is a kind of really interesting way to navigate given my current role at Gender Health SF. The other thing too that I think I often think about is this idea of gender dysphoria as it fits into HIV care and HIV prevention, because there is a real clear connection between providing HIV prevention and care for trans folks, but the experiences of gender dysphoria that impacts risk behaviors and being able to live in one's true self, and having the support system, and that really allows one to thrive and be engaged in the community. And so I think those are the things that I kind of hold today in terms of my role at Gender Health SF and what we're trying to do at the program. So today, I feel really extremely lucky to be the director of Gender Health SF. Again, I credit that to many of the advocates and leaders who imagined creating a program that is responsive to the needs of the community. And that, I credit also through the HIV activism that existed back in the early 2000s, and even way before that, around inclusion and representation of trans folks. So when I think about Gender Health SF, actually this March 2022, or this coming November, I'm sorry, it would actually be the 10th year anniversary of our program here at San Francisco. And why is that meaningful and special? Only simply because it was the first of its kind in the public health system nationally that was developed to address the needs of the communities around surgery access, and really specifically addressing gender dysphoria. And it was created even before ACA was created or was actually passed, including gender affirming surgeries in their policies. And so even way before ACA was passed, the health department in San Francisco was really thinking about how to not just address HIV prevention, but address it from a whole person care perspective, where it addresses the needs of the population. And so, obviously for trans folks, being engaged in care meant having access to trans affirming care, having access to hormones, having access to surgeries, gender affirming surgeries that really impact quality of life, that impact outcomes. And so really pivotal at the time, you think about the context of when Gender Health SF was created. I also want to put into context, even before our program has evolved in early 2010, 2012, so important to think about at the time, gender affirming surgeries was something that was never imaginable for many trans and non-binary folks to access because of the cost, right? Many folks have had to either engage in sex work or have saved money or a bunch of other things to access medically necessary transition-related care and surgeries. And so just kind of like when we put that into context, because when we first started as a program, the first cohort of trans people that we serve actually are, trans women in their 30s and in their 40s who have never had imagined having been able to access gender affirming surgeries. Often, many times, it was regulated for folks who had resources and income, but this is, again, for folks who were under-resourced, were poor, and were, when we think about those greatest risk for HIV, this was a major, barrier that has lifted for folks to reimagine what, what access looks like for them around gender affirming surgeries. As part of our work at Gender Health SF, our mission is basically to increase access to quality gender affirming care for underserved transgender and non-binary people in San Francisco, regardless of immigration status or level of income. What that means essentially is that we work with the most marginalized, under-resourced trans folks, those who have public health insurance, those who aren't insured, to access gender affirming surgeries. And that's kind of a big, how would you say this, a big shift when we think about access to medically necessary care and treatments for trans folks that addresses gender dysphoria. One of the things that we really employ at Gender Health SF that I think is really key to point out is that, obviously we're a peer-led, peer-driven program, led by a transgender woman of color who has no clinical experience or is not a clinician by background, but actually has a wealth of experience around the community, around activism, around thinking through kind of programs and services that addresses the needs and demands of trans and non-binary people around access to care. And one of the things that I often share with folks with Gender Health SF, which is so unique to our program, is this idea of peer navigation services. One thing that we employ that we use, particularly with peer navigation services, that we employ trans folks who have actually received gender affirming surgeries themselves, and we employ them and have this model of workforce development to train and provide skills and education for folks who have had access to gender affirming surgeries to navigate and support others who are seeking accessing the process of gender affirming surgeries. And that's a really unique model for our program. And I consider that as the heart and soul of the program. It really does provide a really good support system and really supporting our patients to not just have access, but actually having the support that they need to navigate the complicated world of healthcare and surgeries. And speaking to the work of our peer navigation services, they provide, again, resources, information to help patient reach their goals, provide group on one-to-one patient education, offer supports in the surgeon selection process, teach self-advocacy skills with patients, accompany patients to appointments as needed, provide peer-led groups and education and post-operative groups, engage patients in wellness in preparation for surgeries. I mean, those are kind of the most crucial thing to think about in terms of programming services that are effective, that is responsive to the needs of the community, that not just, here's access, but here's really good care and really good support that will allow you to have someone to partner with, navigating the complicated world of healthcare and surgeries. And all of this with the goal of, supporting our patients have good surgical outcomes. When I think about outcomes at Gender Health SF, one of the things that we have many data, over the 10 years that we've been in existence as a program, that shows that there's improved quality of life and satisfaction that address the gender dysphoria or deviation from gender dysphoria that have been reported to be life-saving. That's really important to think about, right? When we think about gender-affirming surgeries and gender-affirming care. These are medically necessary surgeries, and for many, have actually saved lives and improved outcomes. Currently, since we're nearing the 10th year of our program, we have processed about 1,500 surgery referrals. You think about kind of where we're at today from 10 years ago, and have about 736 folks since inception. And then completing about 800 surgeries thus far. That's a major, I think milestone itself that I want to kind of put out there, because when you think about kind of population estimates of trans folks, particularly in San Francisco, that have been put out by our department, there have been estimated population size of trans and non-binary folks to be around 1,600, right? And to imagine that we've hit like about half of those folks, or half of that that data point around being able to serve that amount of folks over the past 10 years, that's a huge milestone itself to celebrate. As I mentioned earlier, when we first started as a program, we really supported trans folks who would have never imagined that surgery would be accessible to them. We serve poor and under-resourced folks who now have access to surgeries. We've had successful stories of trans elders in their way past their 60s to access gender-affirming surgeries, and have really improved their quality of life, their esteem, and again, this idea of addressing gender dysphoria. Now, kind of where we're at with the program, we're really imagining having these rich conversations of how we really think about surgeries and what that means for trans folks, right? And having more inclusive conversations around gender-affirming surgeries. What are non-binary surgeries like? What does that really look like? How do we have these conversations that are gonna challenge our notion around, colonize or decolonizing our mindset around, expectations with presenting yourself into the world, and how has that shaped our influences and decision-making processes and accessing gender-affirming surgery. So really important, pivotal time to have those conversations and really think about how we really imagine supporting trans folks to have life-saving surgeries or access these surgeries. And I think about not just the access piece, but then going back to what does good care look like? What is like good, particularly trans-affirming care really look like? And while I speak so much around, what we've created here at Gender Health SF and how we've positioned ourselves within the health department to really create a program that's responsive to the community, I do want to say that there is still a lot of challenges that continues to exist as barriers for trans folks. Obviously, we've evolved as a department to implement SOGI, to provide provider trainings for our departments, provide trainings around good clinical best practices, to provide the awareness of our community in the past 10 years at least around trans inclusion and trans rights and trans visibilities. There's still a lot of work to be done within the department around how do we think about gender affirming care and really responding to the needs of the community. And so, I think one of the things that, particularly with us at Gender Health SF, we're positioned in a way that, when there are things that really come up as issues, and particularly those that our navigators pick up with our patients that they're navigating, and I can give an example. I think one example is, one patient accessed surgeries, and a provider, and was in a PACU, which is a post-acute care for surgery within their system. One provider, while this patient individual was in a compromised position, just recovering from surgery, one individual provider took a picture and with the patient in the background, making a comment around, why would anyone do this to themselves, right? That is concerning and really egregious acts against trans folks, and particularly the system that's really trying to respond to the needs of the population. And so I think, while we've created so much access, you kind of want to go back to this idea of what does good care look like, and how we continue to build the capacity of providers to be responsive to the needs of our patient population, particularly for trans and non-binary folks. And so other things I kind of want to just really highlight is, I think there are really good best practices that are out there around good clinical best practices for trans and non-binary folks, really setting the stage for what good care looks like. There are, really wonderful tips around how you can make your practice, your organization or clinic to be trans affirming. And I think those are those things that really we all must commit to in providing excellent care that is going to be responsive to the needs of the population. So with that, as I kind of end this kind of lens that I offer around, the program that we built here at Gender Health SF, I kind of also want to say that, right now, over the span of 10 years, we've actually been able to navigate and continue to advocate for the needs of the community. And what I mean by that is, we're continuing to evolve as a program where we've, not just covered bottom and top surgeries, but really thinking through what covered surgeries might look like for the community. Thus far, we've been able to cover 13 medically necessary gender confirmation surgeries and procedures, which is a major milestone when you think about like what is covered and what is included, and how we can continue to push and advocate with the health insurance to expand services and coverage for trans folks. And part of that is an ongoing collaboration with stakeholders and community leaders and medical providers who really are committed in championing the issues of trans care in a very complicated system, right? Because I think healthcare itself is complicated, and continue to advocate the voices and experiences that the community wants. When you think about it in a much larger system, is a process, and I continue to credit that to, again, the work of many advocates who really envision the program that is inclusive and intentional and responsive and community driven. So with that, I'm going to end there, and we'll be able to come back.
Thank you, Jenna, so much for all of that. And yes, I really appreciate how you're tying in, like what we've been talking about for the last 2 days, like how important it is for healthcare administrators to see and build their program based on the whole person, all of me, right? See all of me and address those needs. So thank you so much for the work that you do at Gender Health Center. We're going to talk a little bit more, delve in a little bit more deeply when we get to the Q&A session after we have our other two speakers speak. Next up, we have Reverend Valerie Spencer. And I just want to add to the list of accolades and accomplishments and the ways that Reverend Spencer has served our community. She is also the director of the Holistic Empowerment Institute. And so with that, I will turn it over to you, Reverend Spencer.
Good morning, everyone. Good morning. Good morning. First of all, I miss all of you so much. I miss you so much. Many of you know that I am a caregiver for my 83-year-old mom. And because of that and COVID, I've had to walk away from a substantial chunk of my life, really all of it, right? And so seeing you here today makes me glad. Jenna, I didn't recognize you with your hair up. Good morning. Shawn, I didn't recognize you because you got your little sweat. I didn't, but everyone looks wonderful, and it is so good to be with you all this morning. I am sure that with all of the expertise that you received yesterday and this morning thus far, and the remaining of the afternoon, that I'm not going to necessarily add any sort of new concepts to your field of vision. But I do want to amplify a few things and use some of my own life experiences to sort of amplify breakdowns in policy and breakdowns overall. So I'm going to give you some examples of why trans people mistrust whenever we enter the clinic setting or the medical setting. And let me be clear, I'm a therapist, right? I function as a therapist. And these systems of mistrust also take place in the clinic setting, right? In the clinic setting, but also take place in the clinical setting where you are engaging in mental health therapy and so forth. So these same breakdowns, systems breakdowns, happen in the medical setting, that's what I'm saying, happen in the medical setting as well as in the mental health clinical setting as well. So they do apply. So I'm going to start off with the good, the bad, and my least favorite, the indifferent, right? And so even though we love good news, let's start off with the bad. Let's be bad. So I'm going to give you a horrible example. As many of you know, I'm Black, and many Black people live with hypertension, as I have. In fact, something that I really talk about, but I really don't have any transgender healthcare issues. My number one, my primary medical issue is my blood pressure. And so in my 30s, and I'll talk a little bit about that later. But in my 30s, I worked at Charles Drew University, Medical Hospital, the university, all of that. And I had a great doctor, okay, yeah. But since I work at this world-class hospital, let me ask one of the doctors, can you refer me to a hypertension specialist? And so Dr. Jeffries at the clinic referred me to a doctor named Dr. Williams. Don't know his first name because I would quote it. And so I get into the clinic, I make my little appointment, I stroll in. And so the nurses asked me that number one question that trans women really can't stand, which is, what is the first date of your last menstrual cycle, right? Breakdown number one. When I said to them, I don't have a menstrual cycle, I'm a trans woman. Right. They completely did not understand what I meant, which means we have a call for more training specific to this body. Here's the piece. I should not have to inform a doctor or a nurse, a physician of any kind about my body. You are the specialist of human form. You should already know about my body, and I come in and give you some specifics, but you shouldn't be completely green. And that carries over into your documentation, your face sheets, your assessment sheets, your intake forms, all of those things. So because I left the intake form that talked about pap smear, and I do have regular mammograms, pap smear and cervical cancer and pregnancy, because I left that blank, they physically engaged me and asked me, what do you mean you're a trans woman? What? And back then we used the language transsexual. Well, what do you mean you're transsexual? I mean, well, just complete the form. And I said to them, my body is not represented in this documentation. I don't have an ovary. I don't have a uterus. And I cannot accurately answer that. So that's breakdown number one. We need more medical training. And then breakdown number two, we need for trans bodies, we need for gender variant bodies of every form to be reflected in some kind of way on this intake, on this assessment, on this face sheet. Right. And we need that done with no cumbersome continkery. I just made that word up. No sort of, right, flim-flammery. Just ask the issue. And I have found often, and I travel a lot, which is another thing I miss about stepping away from my life. I find often that these assessment sheets that do have gender variance, trans people, gender nonconforming people reflected on them, if you really peep them low key, there's a lot of bias in there, a lot of judgment in there, a lot of assumption in there. When are you going to get? Wait a minute, I never said I was going to get, right? I haven't made any body conversation yet. So we need some accurate training and development around just how to engage the physical form known as the trans or the gender variant bodies. And we need that done in a way, here's critical, in a way that is not comparative to cisgendered physical form, right? Just talk about me. Don't compare me to Keisha's body. I don't even know her. Right. Talk about my form. Don't talk about my physical form in terms of it does not have an ovary or this or that. Don't talk about my body in terms of deficits. Footnote, I do that enough for myself. Damn it. Just talk about my body in terms of its medical need, right? So we need ourselves reflected on these intake forms. Continuing with the story. So I said to them, you know, I'm a trans woman. I don't really have all that. Ha, ha, ha. I don't have a menstrual cycle. We laugh, we giggle, we go on. They're kind of chuckling. They don't go deep into the information because it's over their head, but okay, cool. They send me into the doctor's examining room. I've got on, now I'm there for my blood pressure, so it's about the arm. Right. I've got the arm exposed. I'm ready for the cuff. The doctor walks in and he says to me, you know, good morning, doctor, good morning. So they tell me you're a transsexual. And I said, well, good morning again. Yes, I am. Thank you for asking. But I'm here for my blood pressure. So anyway, doctor, he says, so wait a minute. How do I know you're a transsexual? And I said, I just told you that I am, right? I just told you that I'm a transsexual. And I'm trying to figure out, like, what is he, like, is he trying to say he didn't know my T? What is it? I don't know. What is he trying to say? And so he says, well, how do I know? How you gonna prove it to me? And I said, I'm not really sure, doctor, why I would have to prove it to you. I'm not sure if you read the chart completely, but I'm here for my blood pressure, nothing else. I'm here for my pressure. He goes out, right? Breakdown, yes, again, let's go to the breakdown number two. This was a physician that obviously he either had surpassed his training or did not have enough training on how to engage sensitively with your clients, right? No man doctor should walk into a woman and just say, so tell me about your titties, right? That's not even the way you engage in a patient-provider relationship. So that's breakdown one. Respect my personhood. Respect the fact that I'm an adult. Respect the fact that I'm a consumer and you're not doing me a favor. Right? You're not doing me a favor. In fact, I'm paying for this, which makes me as a consumer with a side eye, because you better do right. So he goes out, he comes back with his gloves in his hand. He's beginning to put on the gloves. And so he says, you're a transsexual, right? I said, yeah. He said, well, show me your nuts. This actually happened to me, right? This is not like, I didn't write this in a creative writing course. This actually happened to me. Show me your nuts. Now, footnote, right? Footnote, let's step off the lesson for a minute. Footnote, trans women particularly trans women of color. And I don't want to be, I'm not trying to obviously leave my brothers out. I'm just not privy to the experience. So correct me if I need to be corrected. I yield to that. Trans women, particularly trans women of color, have had to get familiar with the spontaneous perversions of cisgendered men who want to interact physically with us, right? We have had, and now that's a low down dirty shame. And it even takes place in the hospital setting. We've had to deal with the spontaneous pop-up of perversion, meaning we're at the phone bill place trying to pay our spent bill, and somebody walks up to you and asks you, are you fully functional? Right. We've had to contend with the perversions of people who want to fetishistically engage with us. And sometimes, how big is it? We've had to deal with the spontaneous perversion of people who are fascinated, fixated about the sexual prowess of our physical form. And that even translates into the medical setting. This man is asking a chick who came in for a blood pressure consult to see her nuts. Now, am I going to trust you? No. If we even got past this and went back onto a blood pressure lane, do I trust anything that you say? No. Why would I? No. Do I trust the whole medical system? No. Does this reinforce my ongoing conversation of doubt? No. Does this translate? Does this experience with this physician about my blood pressure, does this translate over into if I'm on HIV meds, let's say? Am I going to trust anybody's consult about my medical needs ever again? No. Why? Because I've been tangentially raped. Certainly exploited, but I've been basically raped by this gentleman who is denying me appropriate care in lieu of having his sexual or his whatever child. So I asked the doctor, I said, doctor, you trying to holler at me? You trying to get some? Right? You want to take a girl to get, you talking about seeing my nuts. You want to talk about my wine selection or who I think has the best salmon or what you trying to holler? What is this? Right? And again, with that sexual fetishistic, spontaneous perversion, we've had to contend with, even in the medical setting, people who are asking us for sexual curiosity, even though we are just there asking for a peppermint or for housing or for HIV meds, or in my case, a blood pressure check. That's a breakdown. We need training, more training for medical clinicians so that they don't have to bring these perverse curiosities into the clinic setting. Right. Now, I got past that. I put on my clothes. I left. I went shopping. And Blue Cross Blue Shield, actually, he sent me a bill, believe it or not. And I had to go on a long fight so that he did not get that $67 out of me. But the system of his behavior, I don't believe it changed. The system of his behavior changed. And should I complain that this was the way he engaged with me, you all know I would have heard all of the reasons, right? I'm just trying to learn. We're trying to expand our knowledge base. Well, we've never had a patient like this. So you're going to tell me the supposition is that your means of gaining information is to ask me about my nuts, right? Inappropriate behavior, breakdowns in education, breakdowns. Now, the other breakdown is that we need an overall medical respect for both the trans intellect and the trans body. I know what the heck I want. And if I tell you I want hormones, I don't need for you to give me a long questionnaire about what is my life span going to be. Am I ever going to run for president? Because give me the moans, honey, okay? We don't need this long process. Respect my intellect, respect my consumership, respect my body. This is my form. So now that's awful way. And the awful thing about this narrative is that I know that my story is not the only story on this virtual, right? You all have these sort of odd, perverse experiences that we have to deal with. And the moral of the story is we need more training. We need more training. We need some consequences. We need some consequences with the board of somebody, right? For me as a therapist, it's board of behavioral sciences. We need some consequences that when these things take place, I can call a hotline and say, look what this brother just did to me. And there will be a conversation. I should not have to fight to start a processing or a disciplinary even conversation about this physician. So that's bad. Let me give you a good. Let's switch to good and then talk about perhaps the systems breakdown that could have supported my doctor further. Let's just get into it. So my doctor, at least back then, my doctor, Dr. Chow, nurse practitioner, I worship the ground she walked. I love my doctor. I love Dr. Chow. And so when I turned 43, 44, I was in school pretty tough. And she said to me, she said, well, Valerie, I have to have a conversation with you. I said, okay, all right. She said, now, you know, we're both girls, so you may not like this because it's a sensitive topic. And I'm thinking, okay, sit back, cross legs, get into my pensive pose. What is she talking about, right? She said, you know, you're at a certain age now. You're 43. I said, yes, I am. I love being in my 40s. You're 43 now. And a woman like you at this stage of her life has to have her prostate examined. Now, in person, this is the part where the audience laughs, chuckles, right? Prostate woman. However, virtually, I can't see the gag, right? So, okay. However, she said to me, it's time for you to get your prostate examined. Now, what was the good piece about that? First of all, she did what the physician must do, right? The other part that I hate, which we'll get to in a minute, is because you're not aware of transness and you're walking on eggshells, you provide me with subpar medical care. If this human body has a prostate and it needs to be examined, your role is to tell me, hey, it's time to examine that prostate. Same with my pinky finger. But you don't omit care because you're not familiar with how you will engage. You need more expertise and experience and exposure to how to engage, right? Much less with a trans woman. The other part about that is that she respected not just my personhood, my consumership, she respected my womanhood. Oh, that was huge. She respected my womanhood. In fact, she verbiaged it in a way that made me feel like it was a rites of passage to have my prostate exam. Like, yeah, I'm a grown ass woman, bitch. To get my prostate exam. I'm finna save and buy me a piece of property. And I'm finna go on up here and get this prostate together because I'm in my 40s. She made me feel proud to have my prostate examined, right? The other piece is that I loved about her was that she did not over-trans me. I'm gonna come into the medical setting and you're talking about trans toothpaste, trans eyeglasses, trans healthcare. Okay, that's why I'm here. Transplant, trans flowers, it's like, God damn, okay, all right. We get it, you know trans stuff. She did not over-trans me. Instead, she interfaced with what she had been presented with, which was my womanhood. And for her, blessed that she is, she did not see a contradiction between having a medical conversation with her woman patient and the fact that this woman patient was trans-bodied. That's my verbiage. It may not be yours, right? She didn't see the contradiction. Therefore, she could flow. It was like scatting, right? A woman like you at this stage of her life has to have her prostate examined. Wonderful. She gave me my honor as a being. And often when we walk into the medical or the mental health clinical setting, we don't feel like a person, a thinking, a sentient being. You know, they don't consider us people with intellect and processes and the ability to research. We're not even consumers. We're just this sort of gender goo that well, let's just quickly stick it with a Band-Aid because we don't want to touch it, right? Sort of piece. She gave me my totality. Now, am I plugged in? Yes. Do I trust what you say? Yes. Am I on your team? Yes. Do I buy, let me tell you, if Dr. Child's not there, I don't care if I am one of y'all up in here with these degrees. If Dr. Child's not here, I ain't got nothing to say, right? That's the kind of trust that we had as physician pay. And that's the kind that we want when we go into the medical setting in general. We don't want to go into the medical setting feeling like we're shooting dice, right? Like we're shooting craps up against the wall and let's see what happens after we want to know that we're going in to have a boundary, right? We're not good girlfriends. You're not going to ask me how big am I going to get my titties. You're not going to ask me how do I tuck. You're not going to ask me where do I meet men? Where do I get the pieces at? Do they all identify as gay? Are they on the... That's your stuff. Become my friend. Get me drunk on a Friday night and then we'll talk. But in the medical setting, you need to regard me as your consumer and call me important. You're not doing me a favor. In fact, if I withdraw myself from this institution, you will no longer have an institution or a job. Respect my game, right? Respect it. So now finally, my least favorite is indifferent. Now that is what I have now, unfortunately. And she does not know this, but I'm getting ready to fire my doctor and get me another one because I cannot stand indifferent. Let me explain to you what I mean by indifferent. It is important when we go, a part of the trust-mistrust ratio, it is important that when we as trans people, as we as gender variant people go into the medical setting, that we disclose, right? That we say, hey, I'm trans. Hey, this is what my body has. This is what it, we need to be fairly transparent. We won't be if we don't trust you. Right. We won't be if we know you're going to be catty. We won't be if we know you're going to go in the back with Miss Millie and dish us. And right, we're not going to be that. But we need to be fully transparent. So when I come into my doctor and say, doctor, this is our first meeting, I just think you should know that I'm a trans woman. I'm not sure if you visually got it or not, but I am. Hi, I'm a trans woman. I have a few specific trans healthcare needs. Here they are. But in general, I'm here for my blood pressure. I'm here for my weight. I'm here for blah, 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 blah. And her response is, okay, so now you're transgender. Okay, right. Now, right. Okay, you're transgender. So I guess that means that you're transgender because you've been on hormones for a certain period of time? No, doctor, that's not what they mean. I'm a trans woman because I was born, right, with what I have, and yet I know myself to be so, okay, so you're transgender because you feel that way, and it's a really strong feeling, and I could, no, doctor, no shade. That's a very nice way of calling me crazy. I diagnose people for a living, so step back, chick. No, that's not what I'm saying. I'm saying that I'm a trans woman. I was born with certain genitalia. We don't need to get into all of that. And then you find yourself, am I teaching? Should I be invoicing you for this? And I had to tell her, doctor, no tea, but this little piece that you got here, I gets broken off a proper piece of change for this here, right? They didn't put this in medical school. Breakdown. We need more training about gender variance in medical school, in residency, in clinical internships, in mental health internships. We need to be intentional about making sure that doctors are exposed to a hearty percent of trans and gender variant people. That requirement needs to be put in curriculum because I shouldn't be in LA. I should not be the first queen you have ever encountered. as a clinician or as a being. And I said to her, have you ever even met trans people before? Because I'm trying not to call you like stupid in your face, but have you ever met trans people before? I haven't. I can't say, not even at the Mac counter, not even at Nordstrom's or something like that. I mean, like at the hairstylist place. No, I can't say. I said, well, doctor, where have you been, baby? Have you traveled? Have you been abroad? Have you lived? Where have you been? This is LA. What have you been doing? I don't know. I just haven't been out in the world. I haven't met any trans people. You're right. You haven't been doing nothing with your life. You haven't met me. You haven't met my people. You are at serious deficit. What's up? I said to her, I said, well, doctor, we'll have more of these. Then I go back in. More of the, okay, so is everything all right with your hormones? Doctor, I've told you more than once that I'm a trans woman, but I am not on hormones. So, okay, let's stop talking about that. Oh, okay, so now what makes it indifferent? The medical process, the examination process, the whole doctor-patient relationship is just fine. As long as we don't touch too heavy on that trans piece. I'm okay that you're trans. I'm sorry, the truck is passing. The street cleaning people are passing in the middle of the day. Why? Like suburban life. Why do this in the middle of the day? So everything about this engagement, about this relationship is perfectly fine. As long as you don't require me, your physician, to delve too deeply into the trans part. Right. Oh, okay. All right. So you don't need any hormones or anything? No. Okay, great. So now let's talk about your A1C. Well, wait a minute. You don't want to engage that trans piece no further? You're my doctor. You don't feel there's anywhere we need to go? Well, you said you're fine with hormones, and yep, so it's indifferent. Right, it's indifferent. There's no knowledge, but there's no stupidity, right? It's just kind of blank, right? And so I'm asking, well, you don't want to ask me about my anal health, for an example. I'm old, but I ain't old. I can still have sex. You want to ask me about my anal health, doctor? You don't want to ask me about like my PSA. Do I need a PSA? Oh, PSA, well, yeah, I can give you some information on that. A PSA is a prostate. Girl, I know what that is, girl. I'm old. I need to be having a PSA, don't I? That's something I would really, yeah. So you don't know anything about me other than my name is Valerie Spencer. And if I void out the trans people and just be female for you, we're good. We're good, right? So we're talking about my ovarian health. We're talking about my pap smear, because they keep bugging me about the pap smear. I keep telling them I don't need no pap smear, y'all. Leave me alone. Well, do you want me to? I can lie for you. No, you're supposed to have language for people like me. And I'm not supposed to coach you. You're the doctor. I'm the ignorant patient. You're supposed to know. You can't be indifferent. You have to know. You have to know. And so I ended up having a conversation with her that said, you know what, doctor? I don't want to be mean to you, but you're behind. And I think we have to have conversations with our medical providers to say, you don't know enough about me and you need to. What's up with that?
Right.
What's up with that?
Right.
You need to. Oh, you're interrupting. Am I going over?
Yes, Rev, you know you did. I didn't even.
I did not know.
I'm
a reverend.
We
go over time for a living. That's what we do.
I know, and you gave us a word today. Can I have a second
to wrap up? Can I wrap up? Can I have a second to wrap up? And I mean a second.
Yes,
and I do mean a second. I didn't know I went over. You didn't give me a little star or something, a little hand clap to say, hey, girl, you just agreeing with me and I'm shade. So I really want to do wrap up on the indifferent part, right? The medical setting is not complete if you don't know about my physical form, or if you don't have avenues for consult about my physical form. It is the equivalent to me coming in with a bleeding finger, right? But because it's not a life-threatening bleed, you're talking to me about my cavity, right? I need you to know about my body. I'm sorry. I need you to know about my body, get familiar about my body so that you can provide me with care. Thank you. Thank you.
Oh, thank you, Reverend Valerie Spencer. That was
Thank
great.
you.
I didn't want to
And I
interrupt
love
you.
the way you all are cramming Reverend Valerie Spencer down my throat. You know, I'm still not used to being called Reverend. It's only been 2 years. And I'm loving the way you're just sort of Reverend. I do need to get used to being called Reverend.
Well, yeah, get used to it because you just gave us a word and you touched on so many levels of the ecological level, which we're here talking about today. You talked about structural issues and personal issues. And I think you really shared information that will be useful for the clinicians and clinic managers that are here today. And we're going to get a little bit more into that when we get to the moderated session. But for now, we're going to turn this over to Miss Gentili and allow her to talk to us and give us her 20-minute talk before we get there. You can go ahead. The floor is yours, Cecilia.
Well, thank you. The question is how Reverend Spencer was not a reverend all her life. I mean, she's been doing this forever. I don't know how she's just a reverend now. So you've been a reverend for so long. Please, you've been giving us the preaching for the longest. You've been a reverend forever. Mama, please. I wish I was as graceful as Valerie was when with the period question. You just brought me some like extreme post-traumatic stress disorder with that. I had a UTI a couple of years ago, and my partner was like, "Let's go to the hospital." It was Saturday night. I couldn't see my doctor, you know, like you have your doctor, Valerie. I have my doctor that understands me and everything. And I had to go to a hospital to meet a stranger. And, you know, all my documentation is also changed to Cecilia Gentili, female. So when they ask like questions for women only, I cross it over because I didn't want to just deal with that. And the triage nurse, you know, went with the question that when was my last period, and I said like I don't have a period, and then she's like, I know you don't have your period right now, but when you had the last one, when was it? And I was like, no, I don't have periods. And then she kind of like called me old because she's like, oh, you don't have a period anymore because you don't have it anymore. But when you had it, when you were younger, when was the last one? And I was like, I don't have a period. And then she thought that I didn't understand English. So she started like doing el periodo, tu periodo. And I was like, girl, I've been having a conversation with you for 20 minutes about my inexistent period in English. What makes you think that I don't understand you? So then she started doing like, you know, a movement. She was like, period. When was the last time you bled? When you bled last time, mind you, it's a waiting room with a lot of people. And it's exhausting and embarrassing. And she's like, please tell me when you bled. And I'm like, oh, last weekend. I'm sorry, it was last weekend. She's like, see, it was easy. I don't know why you didn't tell me. I'm like, yeah. I was like shaving my balls and I cut myself and it bled like a motherfucker. And, you know, she had like a heart awakening to like the reality that, you know, I don't have periods because I don't have what it takes to have a period. And that's okay. That's totally fine. So, you know, you just brought me there. So it was, I tried to make fun of it, but, you know, it is really is funny if it wouldn't be such a like terrible experience, right? And like you say, I got a bill after, a co-payment bill from my insurance for all the suffering that I went through. I have to pay for it. So that is really, really annoying. So I love that you mentioned that, Valerie. So thank you for having me. So hard to follow Jenna and Valerie. I feel like it's nothing of importance that I can say. I'm just gonna introduce myself a little bit, like Shawn said. My name is Cecilia. I have a company called Consulting, and I am the founder of the Cream New York, a coalition that is working really hard for decriminalization, decarceration, and destigmatization of sex work. I do this because I was a sex worker for most of my life. I still do engage in sex work at times, but it's not my most important form of income at this moment. I am also a person who used drugs for a long time, and I do still engage in drug use in a harm reduction form at this moment in my life too, and that it's okay. People who use drugs can also have different jobs and do different things, and that's very important for me to make clear. So. Another important part of my identity is that I live in this country as an undocumented person for the first 10 of the 20 years that I've been here. So half of those of my time here was as an undocumented person, and a half of my time here was as I have had an asylum in this country, and hopefully I'll become a citizen soon, so I don't have to worry about traveling and things like that. But the most important thing of my narrative today for you all is the fact that I, doing this my time in the United States, I mostly supported myself through sex work, which was also the case of when I lived in my country of origin, that is my adored Argentina. As you all hopefully know, trans people, in particular trans women, continue to be at a unique risk for HIV infection. Rates of HIV infection continue to go up year after year since 2015. I think it's about 90% of new infections in the trans community have been trans women. So that talks a lot about like the intersection of being trans, but also the intersection of being a woman, a trans woman. And also the fact that most of these trans women are trans women of color, especially Latinas and Black trans women. And most of the time, these trans women of color are trans women who engage in sex work. And you may ask yourself, why do trans people engage in sex work? It is a very simple question, because sometimes it's the only choice that we have to make our living, right? It's the only choice that we have to pay rent. It's the only choice that we have to eat, right? When I started my transition and I was 17, this person that I met for the first time, the first trans person that I met in my life, I was like really annoying to her. And I was like, please help me. I want to be like you. I want to be like you, I said, I want boobs. How do I get boobs? And she's like, oh my God, you're so annoying. But she says, come back later, in the morning when I finish working and see me, because she was in the streets though. So I came, later, and she says, like, it's 3 things that you need to know. If you want to be like me, you are going to be a whore, you are going to get high, and you are going to die young. And that happens to be the experience of a trans woman in the 80s in Argentina. And if you think for a minute that is any different nowadays in the United States, you are mistaken. For many of us, engaging in sex work is the only way to procure all the things that we need to survive. and sometimes, and we're going to talk a little bit about it, why many sex workers engage in drug use, and it all makes sense, right? But trans people engage in sex work for many, many different reasons. Some of us, want to have surgeries, and surgeries are very expensive. So, some states have laws that kind of cover surgical procedures for trans people, but a lot of us, like in my case, are undocumented, and we cannot access any kind of health insurance, right? And many of us don't have jobs that can offer us health insurance. So supporting this kind of large cost of surgeries is one of the reasons for what we end up engaging in sex work. For some of us, it's a form of income that is available if you have a criminal background, right? Usually, if you start engaging in sex work, because of criminalization of sex work, you're gonna end up with a criminal background, right? And then it's hard to move into other jobs, because when you have a background check, that may come up, right? So the fact that nobody's gonna ask you for a background check to put an ad online, it makes it easier for people to do this kind of work. Also, it can be very validating. I have to say, part of my engagement with sex work was really validating. Imagine, when the rest of the world is telling me that, that I am not worthy, that I am an abomination, that my body is wrong, that I don't deserve to be here. It's all these people giving me money to spend time with me and touch my body, that gives me a lot of validation, though. So for a lot of trans people, specifically trans women, sex work can be very, very validating. Another thing that happens also that is a factor in why trans people engage in sex work is the fact that many of us live with community that already is engaging in sex work, and that is kind of like the normal, right? It's like everybody's doing around you. Why not? Why am I not going to do it? So it is important that, when we talk about the reasons, it is important to know that some of the reasons that a person, specifically a trans person, may choose to engage in sex work are very complex. But, most of the times it boils down to not having enough money and to not having enough opportunities to gain any kind of other employment. And despite being a population that is in desperate need of a comprehensive care that is tailored to our unique needs and risks, trans and gender non-conforming and non-binary sex workers remain extremely undeserved by the medical community. And much of this is rooted in medical distrust or medical mistrust that sex workers have in regards to medical providers. Many sex workers may not fully disclose their risk and needs to a doctor for fear of criminal consequences. Imagine if you go to the doctor, and when you go to the doctor and you disclose your profession, whatever your profession is, that could put you at risk to go to jail. Would you disclose? Most likely not, right? So that's what happened to sex workers. So when we, sometimes we are nervous about disclosing that we are sex workers because our professions are criminalized. And this is why decriminalization efforts are so important. And decriminalization is ultimately a public health issue as well, right? I cannot express why, healthcare settings should really put an effort on decriminalization, because decriminalization of sex work is a public health issue in all levels. So a part of the problem of when it comes to sex work in medical providers is that, you know, we are not able to even disclose, as I said before, what we do for a living. And I remember like me going to medical providers and like, you know, when they do the HIV assessment tool and they ask, you know, do you have sex with men, women, or both? And, you know, first of all, that's a very difficult question to ask because I have sex with much more different set of people, right? That is not just men, women. You know, it is, you know, I have sex with people with different bodies. I have sex with people with different identities. I have sex with groups of people, right? But when it comes to those questionnaires, I remember the question that I dreaded the most was like, how many people did you have sex in the last 30 days? And I was like, oh, if I have to tell you the truth, I had sex with a whole bunch of people because having sex is what I do for living, right? And you know, sometimes you have sex with in between 10 and 20 people because that was my job, right? So I never ever disclose the exact number of people that I had sex with because it is a certain level of shame. And like when I tried to disclose that with a medical provider once, I was looked like I was some kind of like a really crazy person. So I think one of the most important things that we should do is make sure that we kind of normalize the idea that some people engage in sex work. And you may ask, like, what does it mean to be sex worker friendly in a medical setting, right? I think it's really important that we focus on language, right? And language that respect the community and that makes sure that people feel respected, right? Another thing that is important is like not to use patients as your personal Google, right? And either because they're trans or because they are sex workers. It is it is something that happens a lot for trans people and for sex workers. So imagine if you're both, it happens much often, is that when you disclose like your transness or your sex work or your profession, medical providers and mental health providers and case workers, who are like the three pillars of the triangle of healthcare, right? Start seeing you as a Google, right? And you have to answer all these questions. And some of those questions are not important for the professional setting. It's just out of curiosity, right? And you know, a medical provider asks you like, oh, what do your clients ask you for? You know, that's none of your business, like, you know. So it is important not to use, I always say, not to use your clients as your personal Google. And it's also very important to be not defensive and not judgmental, not create any judgment about people who engage in the sex trade. We are consistently surrounded by messages that says that sex workers are either dangerous or irresponsible or manipulative, right? Unless you are in the deep community of sex workers, chances are that those ideas may be affecting you in your perspective and how you see and treat us as sex workers. So it's very important that medical providers take a minute to check their bias when it comes to treating sex workers. You can do that by asking yourself questions, right? When you are providing care, ask yourself, am I responding verbally or through body language that is disapproving of what they do? Am I being more restrictive around medication because they are a sex worker? Am I assuming something about them beyond that of what they're telling me, right? I know that do I have an extra minute, and Shawn?
Yes, Cecilia, you have probably a couple of minutes left.
Yay! I wanted to talk very quickly about sex workers and risk, right? The idea of risk is different for everybody. Most likely, you know, if you are a cisgender person, if you are a medical provider, if you are a white person, you most likely have had an upbringing that is different from a trans person of color, right? And the ideas of risk are totally different. What risk look like for a medical provider is totally different what it looks like for me. Medical providers have like asked me repeatedly, why did you put silicone in your body, right? Don't you know that it's a risk? And I'm like, what risky is for you may be different for me, because I needed my silicone. I needed my silicone, and I knew that I was putting a foreign substance in my body that I didn't know what it was, but I needed for myself. I needed to see that I had an ass and hips that made me look more feminine. I needed to know that I had a body that my clients were gonna want more because it was more rounded. So you see it as risky and I see it as surviving. So our ideas of risk are different. Ideas of risk are different for everybody. Usually medical providers are like, why do you do drugs? Don't you know that it's a risk, right? And when we ask like, why do sex workers use drugs so many times? Some of us enjoy it, right? Some of us are like, I want to get high, right? Why not, right? Some of us enjoy it. Another reason that I engage in drug use, specifically in uppers like cocaine or crystal meth, is to stay awake, right? If I have to pay rent tomorrow, right, and I don't have all the money, and I have to stay up all night, of course I'm gonna engage in something to keep me up, right? Some of us need to stay up to do to make money, right? Another thing that happens a lot is that clients request it, right? Many clients request it. So if a client comes and says like, I'm gonna be with you only if you get high with me. You know, if I need the money, I'm not gonna think it twice, and I'm gonna use, you know, with you because I need that money, right? Another thing that we may engage in drug use while engaging in the sex trade is because we can enjoy sex better. Sometimes the sex that we are having for work is not sex that we want to have. We are just doing it because it's work. And drugs may bring an extra level of enjoyment, you know. And another thing that we use for is because it's part of the environment, you know. Some of us, you know, are in the sex trade. Drugs are very present in many levels, so it is important that we know those things. Last advice: don't gossip about us. You know, what we do for living is not for you to be talking about with everybody. If you need to disclose that I am a sex worker, make sure that you do it in the need to know basis, right? No, if they don't need to know, you don't need to tell them, right? Discretion in documentation is very important. I am a person that went through deportation procedures, and some of my medical records were subpoenaed, right? So I am actually glad nowadays that I didn't disclose with my medical providers that I was a sex worker, because otherwise that would have come across in a negative way to my immigration status. And another thing that I'm gonna go again, use accessible language. When people get nervous, sometimes they get excessively academic or social justicey. So make sure that you talk to people as people, right? And not in an extreme academic language. I believe that's all the time I have. Thank you all so much for listening to me.
Oh, thank you, Cecilia, for that. I mean, you gave some really great nuggets. I love, and I'm going to start with you. We're going to move into the moderated Q&A session. Now I'm going to have some questions for each of the panelists. If Reverend Spencer could join, I don't know. I think they're still back there. She was taking a phone call, but we'll start with you, Cecilia.
I'm here. I'm just doing a little caregiver junk right quick, but I'm listening. Okay, I just can't pop on camera right quick.
Yes, ma'am. Okay, thank you. But Cecilia, to your point, when you talked about like the importance, I wrote this down. That how sex workers won't disclose because both sex work is criminalized, and then if we have a sex worker living with HIV in certain states in this country are criminalized as well, and they're risk of going to jail. And so, one of the questions I have for you is like, what would, in your opinion, let me just read what I wrote here. In your experience, we talked about how does local, state, and national policies foster medical mistrust. I think that comment in of itself spoke to that. I want to hear from you as somebody who works in policy, has lots of policy experience, leading Decrim New York. What policies are needed that could foster trust, that would help to mitigate this medical mistrust?
Of course, and thank you for asking though. Usually criminalization of sex work, we can look at it in different levels, right? This is usually a state issue, right? It's not a way of decriminalizing sex work throughout the nation because it's a state issue. So it is important that we all kind of like do a little bit of research and see like, who is doing some kind of decriminalization efforts in my state, right? I am doing it in New York. I'm trying to decriminalize, the idea of engaging in consensual sex between two adults, because that's what sex work is, right? And sometimes we have this idea of converging like sex work and trafficking, right? Because trafficking is the reason for what criminalization exists, is this idea that by arresting as many sex workers as we can, we're gonna find people who are in trafficking situation. And I'm not saying that trafficking doesn't exist. Trafficking does exist, and people who are in trafficking situation should be helped and supported. I myself I'm a person who was in trafficking situations, right? And I went from consensual sex work to being trafficked to back to consensual sex work, right? And that is some things that happen. It is not consistent. Sex work is not consistent. You can become a person who is being trafficked all of a sudden and then move back into sex work that is consensual. So it is very important that we all try to engage with whatever effort is happening in the state level to decriminalize sex work. Another thing that can be done that is very important, that was very successful in New York City, because the city has no control over state law, right? That's a state law. But check this out. I went to the Manhattan DA, district attorney, and I really annoy him. I know the shit out of them at that office. And I was like, if you choose not to prosecute prostitution arrest, is not a reason for the police to go and arrest us. Because why is the police gonna go and arrest you if the DA is not gonna prosecute it, right? And guess what? They came up with a statement that they would not prosecute any prostitution arrest and that they would not prosecute any unlicensed massage parlor arrest. Mm-hmm. And for that, the police doesn't even do raids anymore, right? Because why are they gonna spend money and time if the DA is not gonna prosecute it? So engaging in the local level, brainstorm and find ways on how to support decriminalization in other ways is really, really important. And I'm here to help anybody who wants to do that.
Yes, and just reminding everybody that you have your own consulting company that works exactly on those issues, and they can follow up with you, and you'd be happy.
Shameless plug. transequityconsulting.com, honey.
Yeah. So before I move on to another panelist, we have a question in the chat, and I think this is relevant because I was thinking the same thing. It's like, well, how would I teach that? How do you suggest providers go about asking? You talked about sexual risk history taking, and like how in having those considerations of someone engaging in sex work, maybe or not living with HIV, but then adding on another layer when we're seeing all of what's going on with people, right? They may have an immigrant status. Like, and to your point about like how you knew not to talk about that, because once you got to your hearing, you were glad because it could have potentially prevented you from being able to stay, right?
Yeah.
So the question is, how do you suggest providers go about asking patients about sexual history to make sure they receive accurate information without, I would add to this, without putting them at risk for, criminal persecution, or also without sounding judgmental, because, having multiple partners, blah, and all the things that come with that.
That's an excellent question. One of the things that we have to know is that usually this assessment, the one that I was talking about, is not done by doctors. It's done by patient navigators. So one of the best things that you can do, hire a patient navigator who is a sex worker, who is a trans person, right? Who has an understanding of what undocumented people need, right? We are most likely more open to be truthful about our answers when we see ourselves in the person asking the questions, right? So hire the communities to do this work is very, very important. Second, if you're doing these questions yourself, as I did while working in a medical setting, I say like, hey, I'm gonna ask you how many people you have had sex in the last month. I want you to know that some people answer 0. And some people answer 200 or 300, right? Whatever the number is, I'm not here to judge you. I like to know what is the closest number for what you can remember of people that you had sex with, right? Another thing that you can do is explain to these folks where that information is gonna go, right? Because if that information is gonna go into your chart, you may not want to fully answer that, right? But if you're truthful and you are like, this information I want to know for myself, and this information I want to know because it's going to go to your chart. So you can say, hey, I had sex with 300 people last month, but I don't want that in my chart. So put 10 only. That's what I'm going to answer. But in between you and I, we have this understanding of why am I not disclosing the truth, right? So get that communication part, right? Get that communication part. Take a minute to fully understand why people may not want to disclose everything. Yes. And be cool while doing that. Don't do all the academic bullshit. We know that you know words. It's fine. Just be cool too.
Yeah, it's not, providers have to, get flexible in terms, especially when working with populations dealing with, such significant disparities. You have to get flexible. You can't always go by the book. We need some accomplices in these healthcare settings to help bring us through, right? And so that we can get the care we need. And just speaking of that, I want to move on to you, Jenna. And I know about Gender SF, of course, and I know the work that you do, and I know that you have a predominantly trans-identified staff. And we often talk about as trans health educators, the importance of that, the importance of hiring trans people, the importance of trans leadership, speaking to this leadership we have on this panel. But I'm wondering, are there also ways in which having an all trans staff might perpetuate medical mistrust among trans patients? And if so, what are they and how have you addressed this issue?
Yeah, that's a really great question. Think about like medical mistrust, particularly for trans staff. I think it's really interesting because I think having trans staff and having navigators, and particularly having staff who look like the patient population to serve them, really challenges our medical providers in the way in which we think about culturally congruent programming and services that really speak to the needs of the population, right? So I think it really challenges that. And I think, generally in healthcare, there are dynamics that happen too, right? When, you have entry-level peer staff who may be the first, who may be entering into this field of workforce development and supporting other trans folks, never having any kind of background or history in doing that. really kind of bringing their full selves into the work and advocating for the patients. And I think that is the benefit of having peer navigators and staff who really can speak to the needs of the population. I think in terms of just perpetuating stereotypes, I don't necessarily know if it perpetuates, but I think it challenges the way in which we think about like really peer-driven services and how we support them in our systems of care. And what I mean by that essentially is that I think while we believe in this model of workforce development and really, hiring trans folks, it challenges us to really think about systems that are in place to support trans folks to thrive and be successful in the workplace, right? I think that's a really crucial thing to think about, because I think when you are, bringing your full self to work, that's related to your identity. There's a lot that happens around kind of boundaries and vicarious trauma and, getting support, navigating kind of our own systems that are not necessarily, affirming to trans individuals and trans staff. And so really, I think if anything, it brings us to really challenge the way in which we think about systems that would be responsive to the needs of creating an inclusive and healthy workspace for trans people and trans staff to really thrive in.
Right, right. And I know we've talked about this a lot, like how important that is. You can't just throw someone in there without really addressing all of them and making sure that, because one of the mistakes that I've seen made in programs is that we definitely want to hire and elevate trans leadership, but we can't just put that person in there because we're setting them up. And so this is something for folks to think about in hiring trans staff. Make sure that you're going to have the capacity to develop that person, to look at all of the things that they're going to need for all of them, right? Thank you, Jenna. I want to move to Reverend Spencer now. And we didn't get to talk about your role or the part of you that is the therapist as much. You did mention it, but I think in this context, and as we're talking about how we're trying to intervene or interrupt medical mistrust in trans communities, we know that mental health providers have the ability to allow or deny access to transition care, right? And so as a mental health provider, do you feel that this level of gatekeeping prevents trans people and non-binary people from getting access to the mental health care that they need? In addition to, like, we know they need a letter, right? We know they're going to have to go through that. But because there's this level of gatekeeping about, whether or not you're trans enough, whether or not we're going to move you through, this could be a barrier to not only getting that part of their need, but also other trauma-informed care, mental health care. We all need some form of that. Being trans, kind of comes with being traumatized for many of us. So what do you think about that?
Plus, I'm Black, so that adds to the trauma. We love to omit race, but I live in a racist environment. In fact, I'm currently the resident of a property that was stolen, right? I'm kind of squatting. This space called America was, there ain't no pink slip for it, so we must include race. So I would like to lift up that depends on the clinician in question, right? In terms of the role of gatekeeping. So I'm not able to write letters just yet. However, I can say that part of the letter writing process and part of that therapeutic process it is not meant to screen who is trans and who is not. Again, I said that this instrument is in the eye of the beholder. It's in the hand of the clinician practicing it. And certainly that opportunity to be a gatekeeper in that way is there. And woe unto you if you are doing that, trying to find out who is a real transgender and who is not. But let's be mindful that we are still coming out of that consciousness of real trans, real not trans. As a people, as a trans people, we're still moving away from that. We don't use language like transvestite, transsexual, pre and post-op. We don't really use those. Some of those have just become exclusively medical terminology, such as pre and post-operative, right? But we're still moving out of, as a community ourselves, in terms of who's real trans and who is not real trans, and the phenomenon in place that makes you worthy of being called real or not, right? And so certainly the clinical community, the mental health community, kind of started that junk in the first place with the diagnosis of gender dysphoria. but it's in the hand of the clinician. I will say this, that there are a lot of people who have diagnosed themselves as gender dysphoric as a means of explaining, rationalizing, or defending, unfortunately, their transness. But transness and gender dysphoria are not the same. They're not the same. They're not the same at all, right? But gender dysphoria has been used as verbiage to pimp the system on itself. Right. And then so in that regard, gatekeeping is good for us, because if you can diagnose us as gender dysphoric, then here in California and other places where there's Medicare expansion, you're going to get hooked up. You know, trans affirming healthcare is popping in Obamacare if you read the verbiage, right? So in some cases that gatekeeping is helpful to us. But in other cases, we do want to see what other traumas are in place. We do want to see as clinicians what other therapeutic assessments must be made. For an example, is this someone who is trans, right? And certainly we have not evolved to the place of having thorough assessments to diagnose the separation between, let's say, schizophrenia and transness, right? And so I don't want to suggest at all that to be trans is to be schizophrenic. No, but there are people who are schizophrenic that come in with a number of presentations that they have languaged, right? And so we don't want people who are actually schizophrenic moving along the course of medical transitioning when in fact they're just in active psychosis. Now that's one piece. Now, can you be trans and schizophrenic? Yes, but that's the clinician to really tease out with you. We need to be companions in this process with you and not get, you know, I can't say who deserves hormones and who don't. What if I'm biased? What if I'm one of those people that say only the pretty can have it, right? And there are those. Well, you certainly look like a woman. Well, let me go ahead and get you on your way, right? We don't want that. We do want thorough clinical assessments. We want trans people and gender varying people who are actually going not through a process of bias, but through a process of therapeutic intervention. They mean a real life therapy. So in some cases, the tools of letter writing and all those things are used as gatekeeping instruments, and woe unto the clinicians who are using their own bias. And what you're actually doing is compromising your professional integrity, hoping that you have it, to do that gatekeeping process, versus those who are having a conversation about, okay, you're trans. Now, what else is here? Let's see what else is here. Some people are not clinically, in terms of mental health presentations, are not clinically ready to undergo with a medical transitioning process. That would add additional traumas that will affect their mental health, both long and short term. And the clinician really has to do, but it goes back to your professional integrity. I don't want you, now this is me as a clinician, I don't want you to not be you. I want you to be you. I just want you to be a healthy and whole you. And I want to make sure that who I'm talking to is present, right? I have had to recommend that we sort of slow the medical transitioning process down. Why? This person is in active delusion. This person is addicted to crystal meth. This person is actively homeless. This person is in crisis, in a mental health crisis. This person has been diagnosed with PTSD, bipolar 1, which is more severe, and they're not only in a hypomanic, but they're in a manic state, which means that delusion of every kind, including I should have breasts on my ear, I may be hearing, right? And so I then have to say, we then have to say, no, we need to slow this process down and do some further assessments, get this client stable. But it's not in any way, in its truest form, meant to guard people away from getting the services and the treatment that they need. It's not meant to do that. But again, that's in the instrument is in the hand of the clinician.
All right.
I hope that helps you. I hope that serves you.
Well, I think that was a very rich answer. Thank you so much, Reverend Spencer. So for the sake of time, we need to move on. We're over time, but I have this one last question I want to hear from each panelist briefly. It's a bigger question, but you'll be able to speak to it because you just mentioned it, Rev. Um, and I think Cecilia brought it up in her discussion about that primarily the clinicians that we're seeing are not representative either our ethnic community or our trans community for the most part. So if folks with white or cis privilege are wanting to do better or be better, what advice would you give them? And Jenna, we'll start with you.
Yeah, I mean, I think for folks who are cisgender or have privilege, it's so important to really just be mindful of how you advocate for community and use your power and leverage and continue to represent the community. If community folks aren't there, really, do the part in kind of advocating and representing the community in your everyday work and championing the issues of trans and non-binary people. And that means by challenging the way you think about providing clinical care, really correcting folks who are misusing pronouns, or just really to kind of center and champion the issues on an ongoing basis. It doesn't stop at when folks are there, but really at every level of our work in ensuring that appropriate care is given to the population or the community.
Right. And to you, Cecilia, try to keep it real brief. I just got ding. We are really over time, but I want to hear your perspective.
I'm just I think it is important to move, I think we got too comfortable with the idea of allyship, right? And with the word ally, right? I think we got too comfortable with it, and everybody that has a fucking trans flag in their door thinks that they're an ally, and that's not it. It is the difference between being performative and being intentional. And I think medical providers and people in the medical care system have got too comfortable with being performing this idea of allyship and not really going out of their way to do the things that they have to do. So I would say the best thing that you can do is kind of evaluate what kind of ally you are, what are you doing, what are you not doing, and what you can do to intentionally support the trans community and the trans people that you see every day, and that you're being paid off to do so.
All right. In 30 seconds, respond to that question for me, Reverend Spencer.
I can't wait to get in on this here. First of all, let me just say to my white family, you all go to those white people meetings and bring back information. We know that there are white people meetings. Y'all go to them white people meetings and bring back information, because these white people are up to something. That's first. Let me just say that allyship has become so clean and sterile and neat. It's a resume piece almost. It's a piece that one puts in a bio. It's a sticker, as my sister was saying, it's a flag. Let me just be clear that abolitionists were not only jailed and imprisoned, but they were murdered for their allyship, right? The Sikhs were burned in America for hiding slaves and helping to navigate the Underground Railroad. I need to see my alleged trans allies, where you sticky at, where you dirty at, where you grime. You clean, I'm clean, where your allyship? If I'm filthy and you neat and clean, where your allyship? I need to see you struggle with verbiage until you really get it. I need to see you clink, clink, clink with verbiage until it's a smooth machine. But right now, allyship is just a stamp, it's a sticker, it's a flag with no real struggle. Martin was in prison with a white minister. He didn't wave at the white minister from across the street and say, put some money on my books if you can, ally. They were allies together, right? And so that's what I want to see from my allies. I want to see you really struggle with language, struggle with the concept of gender variance until you get it past your heterosexualist thinking.
Thank you, Miss Reverend Spencer.
I like how you cut me off, Shawn.
Let me just say, I
like how you cut me off. I'm gonna hire you just for that.
Thank you all so much. There are a ton of questions for the panelists in the Q&A, but we really don't have time for that. But It's been my pleasure to share space with such powerful BIPOC trans women doing the work.
And we want to thank you all for that brilliant panel. Cecilia, Jenna, and Valerie and Shawn, as always, an expert at what you do. We appreciate you all. Listen, we've been going for quite some time, so we are going to take a small little itty bitty break to go get something to drink. If we need to make potty runs, if we need to grab something to eat, we are going to take us a very short break.